Hello, John. Hello, John.
Hi, Melinda, how are you?
Good, good. And you?
Very good, thank you. I believe you're on some leave. Sorry to
Yes, I'm
distract
sorry.
you with that.
Yes, I'm sorry. I missed the morning session. I'm on leave, so I'm just trying to spend time with family. That's all. But
Yes,
sitting at home, I can certainly host the meeting.
no, sure.
Okay.
Happy New Year to you and your team.
Yes, thank you, John. Same to you. They said to me that
Thank
they
you.
enjoyed the morning session.
Yes.
Yeah.
No, there were some interesting cases. They had me a bit on the ropes with the extra fees, however. Those cases look very challenging.
Yes, yes, yes. But I think that article you shared is quite interesting.
Yes, I think we could have some further discussion on that if there's time. But, you know, we've always known from the developed world that we have to get on and do it on day 1 and 2. But in fact, the reference didn't come from me. It came from one of your team. And I intend to look at it quite closely because I think it may make an important point that might make our lives a bit easier and our outcomes a bit better.
I think so. I think I think a bit delayed closure and avoiding osteotomy is probably the way for us. That's what I also feel.
Yeah. Yes.
Yeah.
Yes.
John, do you just want to try and share screen for a minute? And
Let's do
then
that.
I've got a little bit of intro for you, and we can just check your screen share. Yeah, that looks fine. Yeah, if you can just stop sharing for 1 minute,
No
then
problem.
I'll just share the intro, and then yeah, it won't be long. I think yeah, we can actually start it just after 5 o'clock. Yeah, we can start. Hello, good afternoon, everyone. Welcome to the first teaching meeting, which is open to all our colleagues. First meeting of the new year, and I'm delighted to have Professor John Lazarus as our speaker today. So just give me 1 second. Can you see my slide, John?
Yes.
Okay. So today we are really delighted to have Professor John Lazarus as our guest speaker today. He is head of the Division of Urology at the University of Cape Town, which includes Groote Hospital, Red Cross Children's Hospital, and the UCT private hospitals. He has special interest in pediatric urology. He underwent urology training in Cape Town, did the fellowship in 2004, and has also done one of the many fellowships. The one is a mini fellowship in uro-oncology. And we have strong ties with him for over more than 20 years. He worked in our unit for a short while, for about, I think, a 6 months period in late 1990s. And he also has very strong family ties with our department right from its inception. So, John, thank you very much for your visit, and thank you for sharing your views on neurogenic bladder. I will stop sharing, and then you can start sharing, and then you can start your talk.
Thank you very much to Professor Chitnis for that nice introduction and warm welcome, and greetings to all the colleagues. Very nice to have the opportunity to be with you this morning, and I hope that the session was well received. So we're going to talk a little bit today about neuropathic bladders, but in fact it's a focus on urodynamics. It's a talk aimed at the trainees in a sense, because I feel that it's a topic which perhaps the opportunity and the exposure is not so easy. And I'm hoping that at the end of it, certainly the juniors will have a better idea where to use urodynamics and how to interpret it. Let's kick off. So always good to start with a case study. This particular boy, CJ from Mossel Bay, is someone that's one of those patients who you always remember and had an impact on my thinking about how to manage these children. And it's really an illustration of one of the things that I often say to my juniors, and it sounds counterintuitive, but those children growing up in the leafy suburbs of South Africa often get poorer care, in my estimation, than those children often born in poorer circumstances. Now, how on earth could that be? Well, if you're born in a poor circumstance in Cape Town, you're going to end up at the Red Cross Hospital. You're going to be part of the what's called the Combined Spinal Defects Clinic, which has orthopedic surgeons, urologists, even neurosurgeons. We have social workers, we have stoma therapists, and pediatricians. So it's a big collective group of colleagues who are able to offer the best possible care that we have locally. Whereas if you're in the private sector, you often end up under the care of someone who perhaps doesn't have those specialized skills. And I think the case I'm about to show you may illustrate that to an extent. So our boy, CJ, when I first got to meet him, his mother claimed he'd had 66 surgeries. Spina bifida boy, had had hydrocephalus, had multiple shunt revisions, including some vegetations on the heart from that, and required open heart surgery. So you're getting the feeling for a boy who has received multiple operations, but not all of them made sense to myself, very familiar with managing the bladder and bowel problems of neuropathic children. For example, he had painful bladder washouts, so they'd offered him a MACE, which makes reasonable sense, but unfortunately following that, he had small bowel obstruction. And after some time, they had felt the best bailout way to manage the colon would in fact be to offer him a colostomy. And that didn't relate to the small bowel obstruction. It related to how they were planning to manage his chronic constipation and soiling. He'd had multiple orthopedic operations. And regarding his bladder, and you need to stay focused here, the juniors really, because there's quite a lot to take in with this case, but they managed his urinary incontinence, his neuropathic bladder, with an artificial sphincter in about 2015. He'd received some Botox, and when he came to us, he was still in nappies. He had stopped using the sphincter because he said it didn't work. He'd stopped doing CIC, and he wasn't taking any anticholinergic medicines. So we did a micturating cystogram, which I haven't got a picture to show you, but essentially it showed, as you might have anticipated, a small trabeculated bladder, and there was bilateral reflux. The cystoscopy had showed an eroded artificial sphincter, and we deemed that the urethra was unreconstructible because the artificial sphincter was in the posterior urethra, a very difficult area to access to repair. So what to do? I don't know if any of the juniors would like to hazard a guess what we should do with this boy. So in summary, from his urological point of view, he's got a small trabeculated bladder. He's got an eroded artificial sphincter now, an unreconstructible urethra. He's not doing any catheterization, and he's just dribbling into a nappy. I, in fact, didn't look up his upper tracts, but let's say for argument's sake that his kidneys are okay. Anyone's welcome to put their hand up if they'd like, but I think you can be forgiven for scratching your head a little bit about what on earth to do in this particular boy. Well, what we did was we felt we needed to remove the artificial sphincter. And in view of the fact that we had deemed the urethra unreconstructible, we closed his bladder neck. His bladder was small capacity and high pressure, so we did an ileocystoplasty for him and offered him a Mitrofanoff. So he has, for the first time now, been dry with that procedure. We also closed his colostomy and started him on a more conventional bowel washout program, which he's been tolerating. So I suppose the point that I'd like to make out of this complex case, now forgive me for throwing such a complex case at you, but the point is that it is a child who, to my way of thinking, has to some extent not received the optimal management. He certainly received a lot of surgery, but that surgery didn't take him closer to being dry or to protect his kidneys. And we were forced to do quite a lot of bailout surgery, certainly not first-line work, such as needing a Mitrofanoff or removing the sphincter, etc., in order to get him to be clean, dry, and with a protected upper tracts. So I think the lesson for me from this case is the importance of realizing that pediatric urology is about 25% of the work of a pediatric urologist has to do with managing the neuropathic bladder. And we have a lot of these children in our clinics, and they do take special efforts. And I would encourage, if one's planning to build a decent pediatric surgery service that includes urology, that putting neuropathic bladders at the forefront of that, including to try and get a urodynamic service and potentially even a combined clinic with orthopods and neurosurgeons, would be in these children's best interests. So from a junior point of view, I'd like to try and get you to put this particular diagram into your heads. This is now accepted by the European Society for Pediatric Urology as the classification system that we would recommend be used to when we classify neuropathic bladders. As a urology trainee, I waded through something like 5, 6, 7 different systems that have been used to classify the neuropathic bladder. And it's true, they all teach you a little bit about it, but this particular version, it's called the Madersbacher classification, really takes a very simple approach. And it says the problem with the neuropathic bladder is either that the bladder is underactive, in other words, atonic, or overactive, in other words, small capacity with high pressures. The sphincter likewise can be either underactive or can be overactive. And if you're able to think of the patients that you're going to see who've got spina bifida and the neuropathic bladder and able to put them into one of these 4 categories, that will really advance your ability to quickly know what this child is going to need. Let's take, for example, the child here who has, on the top left-hand corner, has got an overactive bladder and an overactive sphincter. That's the worst place you want to be on this chart, because this potentially is a hostile bladder, which may well cause secondary reflux and is likely to cause upper tract deterioration unless aggressively managed medically and then potentially even surgically. The children who have an underactive sphincter, in other words, a sphincteric incontinence, have a completely different problem and need different management. So in order to work out where on this simple diagram your child falls, we're going to need to do a urodynamic study. And much of what we're trying to do on our children with spina bifida, and this would include our kids with valves, because the valve bladder is analogous to a neuropathic bladder, is to answer this simple question: is the bladder safe? That's the most emergency question that we're trying to answer. And this is a cystogram, and this shows us many features of the neuropathic bladder that we would love to avoid. We would hate to get to this point where we've got this very small capacity, Christmas tree-shaped bladder. It's trabeculated, sacculated, and we've got this bilateral secondary reflux. We haven't got a picture of the kidneys, but we might be able to estimate that there is hydronephrosis in this child. So our aim of doing urodynamics is to help guide management to avoid this particular scenario of an unsafe bladder. So the juniors, in terms of understanding what urodynamics is, it's a group of diagnostic tests to try and evaluate voiding dysfunction. I've said that it is really to do with the neuropathic bladder, but it can also be applied to children who've got neuropathic bladder, so-called dysfunctional voiders. And that's going to allow us to attempt to get these children to be continents of urine and to protect the kidneys. In the very simplest term, the micturition reflex has a filling and an emptying phase, and it's perhaps beyond the scope of this talk to talk too much about the basic science of micturition, but it is useful to know the very simplified version of the innervation of the bladder, both through parasympathetic, which causes detrusor contraction, and through the pudendal nerve, which controls the somatic relaxation or contraction of the pelvic floor, and also the sympathetic, which has a relaxing effect on the bladder through the beta-3 receptors. This is really the most simplest version of the conception of micturition reflex. And you've got, if you put an EMG on all of us who are neuropathically intact, we would be able to have an active sphincter. And when we get the instruction from the pons to start the micturition reflex, the pelvic floor goes quiet and the EMG tracing will go quiet as we void. And you can see at the bottom the urethral pressure will drop and the bladder pressure will increase. So this is a coordinated reflex. And any interruption with this reflex is obviously going to cause the neuropathic bladder. And here again, we see the features of filling phase, which should be adequate compliance and sensation to filling. The outlet must be closed and there must be no involuntary contractions, and the reverse will be true for emptying. For those juniors, I'd encourage you to take the terminology a little bit more seriously to do with the neuropathic bladder. In many other parts of our practice, that's not so critical, but I would like to emphasize that in terms of being able to communicate with one another when we're talking about this problem, terminology is important. Not the most interesting part of our studies, but nevertheless very important. And I'd refer you to this document, which is the International Children's Continence Society Standardization of Terminology. And if you look at the, it's really a who's who of pediatric urology there. All the important people who've made contributions in the last 20 years are listed as authors on this particular paper. So please go and look that up. When you've got the strength, read it, and it will improve your ability to communicate problems. So once you've got a child who you think may need it, you need to take the think a little bit further and try and ask what you're trying to get out of the urodynamic study. The reason why that's important is because if you know it's rubbish in, rubbish out, if you know what information is going to be required for the urodynamicist to give you a good report and to try as best you can to get the information before they have urodynamics, this is all going to be important. The other reason is that urodynamics is not a trivial investigation. It is quite a lot of hard work for the urodynamicist. It can be quite unpleasant for the family, and for the child potentially there's a bit of discomfort to be factored in. So make sure your indications are clear and well articulated. Indications for urodynamics, I don't think we need to spend much time here, but it would include some pediatric surgical conditions such as anorectal malformations and exstrophies, as we discussed this morning. But any problem with the bladder may benefit from urodynamics. I'd encourage you to think a little bit about simple urodynamics before you get to doing a full study. History and examination and a bladder diary can take you quite a long way to understanding the nature of this child's bladder. And we make use of a flow rate and a residual volume in many children who we don't feel require a full urodynamics. And that's going to give you quite a lot of information, more than enough information to allow you to work on it. So let's look at the uroflow, for example. All this is measuring the flow of urine plotted against time. And this would be a normal, nice bell-shaped curve of avoiding a normal void. In the middle here, we see a plateau. In other words, likely to be an obstructive picture. So certainly in adults where we've got prostatic or stricturing of the urethra, we may end up by getting a plateau. Where you've got overactive bladder, you get forceful expulsion and the so-called tower. So it's about pattern recognition here. And I'd refer you to a book by Christopher Chappell, who's the lead at Sheffield in the UK. He wrote a book called Urodynamics Made Simple. And I would encourage the consultants to consider getting a copy for the resource center or for your local library. It's a very simple, tiny book. You can read it in half a day. And that book includes these diagrams. So just some more pattern recognition for different kinds of uroflows that you can pick up. So what about the invasive urodynamic studies? And again, encourage those of you who might be interested. We've got one of the few dedicated pediatric urodynamic units in Red Cross Hospital. And Jeanette Wright has trained with some people overseas, and she got a compliment from Anne Wright, one of the people at Evelina in London, to say that worldwide she thinks Jeanette is perhaps one of the best urodynamics people she's encountered. So you would do well if you have an interest in doing some further pediatric urology to come and spend some time learning from her. So the reason it's invasive is we need two pressure sensors, one to measure the abdominal pressure in the rectum, and then one to provide fluid and measure the bladder pressure. This is our setup at Red Cross. And we won't go into too much detail, but one needs to know something about the different phases of the normal filling of a bladder, so-called cystometrogram. One of the key things that we measure is the compliance, which is the fact that all of our bladders should be able to fill at very low pressure until we're really at bursting point before our pressures go up. And measuring compliance is an easy thing once one's performed the urodynamic filling phase. Another key concept to get in your head is the Detrusor leak point pressure. And this Texan Irishman, Ed Maguire, was the one who defined the amount of more than 40 centimeters of water as being critical, representing a pressure at which there is no flow of urine from the kidneys to the bladder. And so obviously a dangerous pressure. So we want to keep our pressures below 40 centimeters of water. And I've given you the definition for how we define the Detrusor leak point pressure there. So, as I said, the most hostile bladders that we get quite anxious about are those where there is decreased compliance. In other words, as the bladder fills, the pressure goes up far more than it should, implying a thick-walled, high-pressure, small-capacity bladder. And the urodynamic picture would look like this. Detrusor of activity is something that you can diagnose on a urodynamics, and it used to be defined as any more than 15 centimeters of water. It's now defined in that terminology document as being any rise in pressure on the Detrusor trace can represent uninhibited Detrusor contraction. Again, if you're interpreting urodynamic studies, you need to review the fact that you've got an abdominal trace, a vesical trace, and a Detrusor trace. And the difference between the vesical or bladder trace and the Detrusor trace, it sounds like it's the same thing. But the Detrusor trace is a derived value. The computer derives the value by minusing the abdominal pressures from the vesical pressures. And so the Detrusor pressure is the real pressure in the bladder. For example, if we are straining or doing a Valsalva, we're going to get this artifact, which is seen here. I don't know if my cursor is shown, but it's seen here demonstrating a rise in abdominal pressure, which will be represented by a rise in vesical pressure, but in Detrusor, it's not represented at all, representing that this is likely to be a cough or a Valsalva that was performed here. So that's a key thing that I try to teach the juniors there in terms of interpreting the urodynamic studies. So that was an artifact, but this is very much not an artifact. You can see the Detrusor is going up, and the rectal pressure, abdominal pressure, is quiet, and the vesical is also going up. So this represents Detrusor instability. These are contractions within the bladder rather than the artifact, which could have been a cough or a Valsalva here. Just skip that for a moment. So the normal urodynamic study, we want to see that the bladder is filling at low pressure at the expected capacity without any uninhibited contractions. A couple of cases to round off with. This is the first case. 10-year-old child with myelomeningocele had worsening hydronephrosis despite intermittent catheterization and anticholinergic medication. And you can see that the capacity was reduced about 2/3 of expected. And it's quite important to know how to calculate the expected bladder capacity in children. And essentially it's age times 30 plus 30. So if you're a 10-year-old, it would be age being 10 times 30 mils plus 30 mils, making it 330 mils in this case. So the leak point pressure was elevated above 40, 42 in this case. The compliance was poor. So this child has a hostile bladder. It's unsafe. And you probably need to review the medical management. Is it being done appropriately? And then consider what other adjuvants, such as Botox or tension ileocystoplasty, might be appropriate to help to save the child's kidneys. In this case, we have a child who was always wet, spina bifida, 14 years of age, and the leak point pressure was very low at 11. And so this is a very different situation. You've got a large capacity, hyper-compliant bladder with very low leak point pressure. And this kid is going to be safe, so there's no trouble with the upper tracts, but the problem here is how to get this 14-year-old to be dry. And that's going to be an issue of addressing the sphincter. And that's usually going to require a bladder neck reconstruction procedure, such as the young D's Lebetter operation. Again, the benefit of doing urodynamics tells you half the picture, but if one's going to invest in such a system, making sure that you can do video urodynamics would be an important thing. And this child here had what appeared to be a normal urodynamics, nice low pressures, good compliance. But if you looked at it under the video, you can see that that's not the case. This bladder looks very hostile. And the reason the pressures have remained so reassuring is the fact that you've got this terrible pop-off into quite threatened-looking kidneys. Again, this is a child who had myelomeningocele, and we see a lot of detrusor overactivity in this child, and it was associated with leaking. This was a child who was non-compliant on treatment, and I think we had I haven't got the picture here, but once we restarted antimuscarinic agents, this child's degree of wetting and these overactivities settled quite nicely. The other addition that's very nice for the full urodynamics is the ability to do EMG studies. EMG is the only way that you're going to diagnose this key feature of detrusor sphincter dyssynergia. And that's a fancy word for describing the fact that when the bladder contracts, the pelvic floor is also contracting. And so there's a dyssynergia because when the normal bladder contracts, the pelvic floor is going to relax according to the micturition reflex. And I'm not going to go into the details of showing you that here, but this was a classic case. Team, thank you very much again for the invitation. It's very much an overview, and I hope it's given you some guidance about how to interpret a urodynamic study. And as I said, those of you who'd like to pursue this in more detail will be welcome to potentially come and spend some time with the department, and particularly with Jeanette Wright, our urodynamics person in Cape Town. Professor Chittis, thank you very much. I don't know if there are any questions from you or your team.
John, thank you. This is just a brief overview of a very complex topic. I just would like to ask you one question before I ask. There are lots of senior colleagues I see joining from India. I see Dr. John Sekabira. I see colleagues from Egypt. So we have a very wide audience. So, John, we still don't have urodynamics here in East London. And what we have been doing, as Larry G and you have taught us over the years, is obviously we go by ultrasound, MCUG, MAC3 scan, and leak point pressure. We still do cystoscopy, we do bladder capacity, and the leak point pressure. So what is your advice? Because at many places, urodynamics may not be available. So how should they investigate, and what parameters should they look at to decide what treatment or what plan should be followed?
Melinda, thank you for the question. I think you're correct. Not every unit is going to have access to urodynamic studies. It's a big investment of personnel and money, and it takes quite a lot to keep these services going. And as you've correctly pointed out, a lot of information can be derived from far more simple measures, and perhaps a video urodynamics with EMG may not be necessary in all cases. And certainly ultrasound is the key. No spina bifida kid really in this country, in this day and age, should be not having an ultrasound at least annually, because one just wants to be reassured that the kidneys are okay. Certainly the MCUG can tell you, as I showed in that picture earlier, it tells you 1,000 things about the capacity of the bladder, the pressures in that bladder, whether there's reflux or not. So very good adjunct to that. Eyeball urodynamics is something that enthusiasts could take on. It takes a little bit of training and can take you to a more clear understanding of the situation. But also simple things like post-mic residuals, doing an ultrasound after the child is micturated, and doing the volume voided chart. In other words, giving a chart to the preparers to get a stool diary, to get volumes, etc. Those things can tell you almost as much as a full video UDS can.
Okay, John, thank you. I think Dr. John Sekabira is still around. So, John, your views, what facilities do you have and how do you manage?
Thank you, Milindi. Actually, I don't manage too many pediatric urology cases. I tend to give them to my colleagues. I must confess, I don't manage so many of the, especially when it comes to neurogenic bladders. I can manage other simpler cases, but not that one. Sorry, but thank you for the invite.
Okay, John, thank you. I see Professor Isam Al-Halabi is here. Professor Isam, your views, any comments? You just need to unmute yourself. Professor Isam, can you unmute yourself and give your comments? Not sure he is able to hear me. I see there is Dr. Rajendra Sauji, who is a senior pediatric surgeon in India, who has joined us. Raju, you can unmute yourself and give your comments or any questions you have. Dr. Sauji? I don't know whether they are able to hear me or not. I will then ask Dr. Selo Machaya, who is our consultant pediatric surgeon here in East London, to give his comments or ask any questions to Prof. John. Selo?
Hi, thanks, Bob. Thanks, Prof Lazarus, for the talk today. It's very enlightening and always just reminds me of what I don't know, which is quite a bit still. But I think that what's important, particularly as you're stating at the end, that a child with spina bifida should at least have a yearly ultrasound just to look at the upper tracts. I think that's something that a lot of us kind of bypass or don't actually follow up on, because there are quite a lot of children that have their spina bifidas or meningomyelocele repaired, but very, very few of them ever get seen in the surgical outpatients. They get seen in a neurosurgery and they never get followed up on our side. And by the time we see them, there's already some irreversible damage at that point. So I think what it's telling us that we need to kind of also have a multidisciplinary approach in handling these conditions, and in having insight and having passing the knowledge on to our neurosurgical colleagues to tell them, once they have seen the child, manage the child and thinking of discharging, then the important thing would be to involve the pediatric surgeons as well in the management of the child, not necessarily obviously in the spinal pathology, but in the neurology, because it's just sad when these kids come in very, very late to the clinic and there's very little you can do at that time, versus instilling good practice early on bowel management, on CIC, starting your Oxybutynin early if necessary, all these things to try and actually make the quality of life better. So I think, yeah, definitely going forward, it's something that we just need to kind of instill, particularly in our center with the neurosurgeons, that it's important to have a multidisciplinary approach when handling these patients. Thanks.
Yes,
Yeah, so
yeah, sorry, go ahead, John. Go ahead.
I agree 100% with what you're saying there. We have at the Red Cross Combined Clinic, all of the Tigerberg cases come to us as well. And they usually managed initially with the back closure and the hydrocephalus with the neurosurgeons, but many of them weren't being referred, and we had to do exactly as you've said, to re-emphasize to colleagues the importance of that. But the point I'd also like to make is that these kids do need a champion. They do need someone that's prepared to take some of this work on, or all of this work, because without that, these children really fall between the cracks. No one usually is particularly interested in taking on this work. Certainly in the private sector, people are absolutely allergic to these kids, in my experience. There's no money to be made out of them. It's hard work. But I would encourage you, if somebody's going to do that, to reach out to ASBO, which is the Association of Spina Bifida of South Africa. They're a very vibrant group of concerned mothers and a couple of nursing sisters, somatherapists, and they've really helped galvanize and spoken for the rights of the spina bifida community, and ensured that children that they are involved with get the best possible care. They run outreaches, so they'd be happy to come to East London and begin building a group of mothers and trying to offer support. So there's a lot that can be done with these children, but it really takes somebody who has got an interest to take it a bit further. I see there's a comment there, Milind.
Yes, I'll just, before we take that comment, I'll also like to concur with what Selo has said. And in the first 10 years of our practice here, we used to do spina bifida operations ourselves. We used to do bilomenincocele closures, and we used to put shunts in them. And it was much easier because those were our patients, and we continued to follow their bladder and bowel. But I think once we have handed over that work to neurosurgeons, I think we just need to keep reminding them that they need to refer the child as soon as possible to us for the management of their kidneys and for the bowel. I will just then go to, there are two questions asked by Dr. Kalota from Zambia. What is the ultrasound follow-up protocol in South Africa? And then yeah, okay. The second one is a comment that he says that they also see a lot of them in Zambia, but also disheartening to see how you don't have urodynamics and all as you asked. Okay, so John, your advice about ultrasound follow-up for these children with neurogenic bladder?
Yes, I think that part of the problem is about who's going to do the ultrasound, because it ends up being a lot of work. And what we've tried to include is making sure that our trainees get access to doing ultrasounds themselves. We found that we can buy these wireless ultrasounds from China for about $1,000 US, so it's relatively affordable. And you know, the colleagues should have access to that at all times. So there should be no excuse for our juniors not being competent to do bedside ultrasound. And but that's not really answered the question that was asked. The question that was asked is how it should be done. And I've no doubt that there are guidelines. I'm not familiar exactly with what they would say. But the point is that these children are at risk for upper tract deterioration, which is usually silent. And you know, at least once a year, we have a child who has not had any ultrasounds for a couple of years and comes in with a creatinine of 1,000. And clearly, we've just got to emphasize that these children should at least be having one once a year, ideally, I suppose, twice a year.
Professor Isam, can you just unmute yourself and give your comment? While I'm waiting for Professor Isam, Dr. Sauji is asking role of alpha blockers. John?
Yes, so alpha blockers are agents used commonly for men with benign prostatic obstruction, BPH, and would relax the internal sphincter. I don't think they have much role in the management of neuropathic bladders. There will be some people who have tried them, but they haven't really found their way into first-line management of kids with bilomenincocele. Our ladder or stepwise approach to the pharmacology here would be to institute Oxybutynin. And secondly, for those who can afford it, we much prefer to have them on one of the newer agents, the M3 receptor selective antimuscarinic agents like Vesicare or solifenacin. and we're also using where in those who can afford it, and for motivated parents where there's a problem with oxybutynin, we would use the beta-3 agonist betmega, mirabegron. And the reason why I think we need to be, again, articulating the rights of these patients is that oxybutynin is a dirty drug, and it has CNS effects. And in the elderly and in the vulnerable, like our spina bifida children, these drugs cause cognitive issues. And certainly, I think if as a country we could afford it, we certainly should no longer be using oxybutynin. But we're not in that position. So it really remains our first line drug. But for those who can afford it, we'd much prefer to have them on the newer agents. We're very fond of using intravesical oxybutynin. We crush a 5 milligram tablet twice a day in 20 mils of boiled, cool water, and we inject that with the next CIC. And that's been shown in some studies to be avoiding the first pass effect and to be as efficacious as giving it per os. So that for motivated parents, because it does take a little bit of extra effort, crushing the tablet, making up the solution yourself, but that certainly is something that could be contemplated.
Okay. I see Dr. Uzair Juma is here, and he trained at Red Cross. So Uzair, anything to share from your training at Red Cross? Anything you would like to share with the rest of us? Is he there, or maybe he just left and I don't see him there now? He was there a minute ago.
He is there. He's just unmuted himself. Are you there, Uzair? Maybe his microphone's not working.
I don't see him in the list of attendees now. Maybe he just gone out. Yeah, anyway, I think, John, final comments from you? Just a take-home message?
Yes. I think that urodynamics is not essential. It's a nice to have, and certainly we'd welcome in Cape Town anyone who wanted to learn some more about full urodynamics. But I think, as Professor Chistness has pointed out, there are a lot of equally valuable and simpler tests that can give you the same information. So thank you much, Milind, for the opportunity to talk tonight.
Okay, I see Uzair is here. Let's just try and see if we can get any comment from Uzair. Uzair? Uzair? Uzair, are you able to hear me? No, there seems to be some problem. I can see him here, but I'm not sure whether he is able to hear me or not. I will post the link to the recording in a short time. Uzair says he's got problems with his mic, so it's no problem. Thank you, John, for your visit and for sharing your knowledge and skills with our team in the morning, and for your talk now this afternoon. The next talk will be on Tuesday, 8th of February, and it will be delivered by Dr. Mane, who is a senior pediatric surgeon and urologist in Mumbai, and he will be talking about surgery for disorders of sexual differentiation. So thank you very much, everybody, for attending, and we will see you in a month's time. John, bye-bye.
Thanks, Milind. Bye-bye.